everyone. Just as in our everyday lives, even in ophthalmology and vitreoretina, we often come across situations that make us pause and say oops. This is one such situation that we recently encountered at our center. I present to you the story of a middle-aged myopic male who we had operated upon 2 weeks past for a rhegmatogenous retinal detachment. He presented to us with a recurrent detachment with breaks on his inferior lasered periphery and proliferative membranes over the inferotemporal arcade. We took him up for a repeat VR procedure and proceeded with the dissection of membranes first. We employed a microvitreoretinal blade to try and raise an edge of the membrane to further assist our peeling. As we tried to do this, the membrane at this time seemed taut to us already. We then shifted to the use of a forceps to gently try and pull the membrane away from the underlying retina. But as we pull on this densely adherent membrane, a few small hemorrhages started appearing in the adjacent area. With one more tug, our heart sank and we muttered a low oops. However, we decided to keep our hearts in check and proceeded further with injection of PFCL and diathermy of the brake margins. We attempted removal of the membrane with quite a few other instruments again. However, our attempts were in vain and we decided to abandon them for more atraumatic ways. We shifted to a bimanual approach at this time and employed the use of a scissor along with the forceps to sequentially delaminate the membrane in small strokes. Slowly but surely, the membrane peeled off and we proceeded further with removal of PFCL and securing the brake with more diathermy. At this point, we shifted our attention to the other proliferative membranes in the retina, but our lessons had already been learned very well. Yet again, we employed an MVR blade to raise an edge of the membrane and try and pull it away. Upon shifting to the forceps at this time, we gently teased it away in a tangential manner without applying too much of a pull. With multiple regraspings and multiple tangential strokes, slowly but surely the membrane started to give way. Look at that, we now have our membrane, and this time with no casualties either. We went ahead with the fluid air exchange and drained the residual SRF from the brakes as well as any residual fluid present over the disc. We further strengthened the brake with endolaser retinopexy around it and then injected silicone oil into the eye. We wanted to ensure absolute strength of the retina, so we then proceeded to add quite a few more rows of laser to the entire retinal periphery and more so in the area having the breaks. And at the end of it all, we achieved a well-settled retina post-operatively with a stable BCVA and quite a few lessons learned on our part. We suggest always trying a test of membrane adherence before proceeding to pull at them. If they separate easily, do continue. But at the slightest hint of traction, especially for trainees, shift to more atraumatic ways. Even then, peel them off in tangential strokes, and most importantly, always maintain your calm and you shall conquer it all. Hope you liked and enjoyed our video. Thank you for watching.